There's just 66 of you, but since it's already past 12, I will begin the class. We will continue with our topic, laryngeal paralysis. We have finished the details of the nerve course in the previous lecture. Briefly, we have discussed the nuclei of the vagus nerve present in the medulla, namely the namely these three nuclei: nucleus ambiguous, the dorsal nucleus, and the nucleus of tractus solitarius. The ambiguous provides the motor fibers, and the dorsal nucleus provides your involuntary smooth muscle efferent fibers, which have a parasympathetic function. The sensory fibers or the efferents are to the nucleus of the tractus solitarius. So, in short, the fibers from all these three nuclei form the vagus nerve inside the brain, and it passes out through the skull through the jugular foramen. Before it passes out through the jugular foramen, it bulges to form the superior ganglion of the vagus. And after coming out of your jugular foramen, it forms an inferior ganglion of the vagus, also called as the nodose ganglion. So at the base of this ganglion, just after this, immediately at the base, you see that the first branch of the vagus is given, which is your superior laryngeal nerve. This is the pharyngeal branch of the vagus. This is the superior laryngeal nerve. After giving the superior laryngeal nerve, it is in a medial relation to your internal and external carotid arteries. 2 centimeters almost from the nodose ganglion, though in the picture it appears to be larger. This is only 2 centimeters. This superior laryngeal nerve divides into an internal branch and an external branch. The internal branch is in relation to your superior thyroid artery. It is medial to the superior laryngeal branch of your superior thyroid artery, and it pierces the thyroid membrane 1 centimeter anterior and superior to the ala of the thyroid cartilage. So after this internal branch of the superior laryngeal nerve pierces this membrane, it passes submucosally in the piriform fossa and ultimately innervates the superior portion above the level of glottis of the larynx, giving its sensory supply. There is one branch which comes from your internal branch of the superior laryngeal nerve, which we call as, this branch. So there is one posterior branch, which along with the posterior branch of your recurrent laryngeal nerve forms your ansa of Galen. Okay, it's called as the nerve of Galen. So this branch, this posterior branch from your internal branch of superior laryngeal nerve is called as the nerve of Galen. This, along with the posterior branch of your recurrent laryngeal nerve, forms an ansa of Galen. Okay. Then the external branch of the superior laryngeal nerve, it is also in relation to your superior thyroid vessel. Yes, it usually is seen posterior to the superior thyroid vessel. Then it passes along the oblique line of the thyroid cartilage. Yes, once it reaches your inferior constrictor muscle, it gives a branch to the inferior constrictor, and after going further, it goes behind your sternothyroid muscle and then supplies your cricothyroid muscle. So cricothyroid muscle is the only muscle of the larynx which is supplied by your external branch of superior laryngeal nerve, whereas all the rest of your muscles are supplied by branches of the recurrent laryngeal nerve. So after the superior laryngeal nerve has been given, the rest of the vagus traverses down into the thorax. So here, initially, here we have seen that this is medial to your internal external carotid arteries. This happens to be a little lateral to the internal carotid artery, and coming lower down, this relation is anterior to your common carotid artery. So once in the thorax, you will notice that the vagus nerve course on the left side is longer than that of the right side. Why is that? It is because the left recurrent laryngeal nerve is given out at the arch of aorta, in front of the arch of aorta, whereas your right recurrent laryngeal nerve is given in front of your right subclavian artery. So as we know, this is the arch of aorta. This will be your brachiocephalic artery, right brachiocephalic artery. This will give your right subclavian, yes, and right common carotid, whereas the rest of the two, that left subclavian and your left common carotid, directly arise from the arch of aorta. So this obviously means that your arch of aorta is at a lower level compared to that of your right subclavian artery. So the recurrent laryngeal nerve on the left side is longer, given out in front of the arch of aorta. It turns around or curves around the arch of aorta and then goes upwards. Since it goes in the opposite direction of its mother nerve, we call it a recurrent course. So it traverses up in the tracheo-esophageal groove. Similarly, on the right side also, once it curls around the right subclavian artery, this nerve goes in the tracheo-esophageal groove upwards, and ultimately it supplies all the muscles of the larynx, piercing in relation to the cricothyroid joint. It enters the larynx and supplies all the muscles of the larynx, their motor supply, and sensory supply to the larynx is also given by this nerve below the level of the glottis. Whereas above the level of the glottis, we have seen it will be your internal branch of your superior laryngeal nerve. So this is what we have discussed in the previous class. I just wanted to summarize it. So furthermore, going ahead in the class, you need to know the course of the nerve to localize the area of pathology. Again, we have also discussed the laryngeal musculature, intrinsic laryngeal musculature. So the only adductor means the muscle which is responsible for the cords to move laterally away from each other. The only adductor is your posterior cricoarytenoid. I'm sorry, abductor. The only abductor is your posterior cricoarytenoid, whereas there are multiple adductors, mainly your lateral cricoarytenoid or your transverse arytenoid, then the cricothyroid muscle, then also your external part of your thyroarytenoid muscle. So we have to see that the thyroarytenoid muscle has three parts. Okay, so there is the thyroarytenoidus internus. This is the vocalis. Okay, and there is a thyroarytenoidus externus. So this is one of the major adductors of your vocal folds, and there is a thyroepiglotticus. This shortens or relaxes the vocal ligaments. So muscles can be divided into abductors, adductors, tensors, and muscles causing your closure of the inlet of the larynx. The only abductor is your posterior cricoarytenoid. Adductors are your lateral cricoarytenoid, transverse arytenoid, cricothyroid, and this externus part of thyroarytenoidus. Yes, the tensors of vocal cord, main tensor is your cricothyroid muscle, which is supplied by your superior laryngeal nerve. The other tensor happens to be the vocalis, that is your internal thyroarytenoidus internus. This also causes tension on the free edge of the vocal cord, and there are again muscles which close the inlet of the larynx during deglutition. These will be your oblique arytenoid and your airy epiglotticus or your airy epiglottic folds. So these are the various muscles. So coming to the laryngeal paralysis proper, we will start with the recurrent laryngeal nerve. So you have to note that vocal cord paralysis is a sign of a disease. it by itself is not a diagnosis. So something causes vocal cord paralysis. It is not by itself a diagnosis. And this lesion causing vocal cord paralysis could involve the entire vagus nerve, that is, vagus nerve at a level before giving out branches such as your superior laryngeal nerve and recurrent laryngeal nerve, or it can solely involve the superior laryngeal nerve, or it could solely involve the recurrent laryngeal nerve. So it will be either a recurrent laryngeal nerve paralysis, unilateral or bilateral, superior laryngeal nerve paralysis, unilateral or bilateral, and complete laryngeal paralysis again will be unilateral or bilateral. To begin with, the causes of vocal cord paralysis other than the idiopathic causes will be supranuclear, above the level of the nuclei, which is very rare. Nuclear causes, mainly it involves the nucleus ambiguous. We have read about this. This is the major motor supply. This could be seen in conditions such as lateral medullary stroke, in encephalitis or meningitis, that is inflammation of the brain parenchyma or the meninges, poliomyelitis, we know this, multiple sclerosis. Multiple sclerosis is a demyelinating disorder of the nervous system. It affects the nerve sheaths, so the transmission of impulses through the nerves is affected eventually. Then there is a glioma, tumor of the glial cells. There could be diffuse arterial sclerosis. There could be a basilar artery occlusion, and also in conditions of Guillain-Barré syndrome. So this is Guillain-Barré syndrome is an ascending peripheral nervous system paralysis, usually seen in post-viral conditions. So all these could cause a nuclear level of vagus nerve paralysis. Next will be your high vagal lesions. So the vagus nerve may be involved in the skull or at its exit from the jugular foramen, or it can also be involved in the parapharyngeal space. So all these high vagal lesions injure the vagus nerve or destruct the vagus nerve before it gives out its branches. So these high vagal nerve lesions always cause a complete laryngeal paralysis, may it be unilateral or bilateral, it causes a complete paralysis. So these conditions will be in intracranial aspect, there will be tumors of the posterior fossa, basal meningitis, most often tuberculosis. At the level of the skull base, that is at the jugular foramen level, you can see fractures, skull base fractures. There could be a spread of the nasopharyngeal cancer, spread of the glomus tumor. There could be skull base osteomyelitis. And in the level of the neck, there could be conditions such as your penetrating traumas, parapharyngeal tumors, metastatic nodes, and lymphomas. So these can cause high vagal lesions. The next will be your low vagal lesions. That is, the superior laryngeal nerve is spared here, and 2 centimeters below the nodose ganglion, immediately below the inferior border of the nodose ganglion, you see the superior laryngeal nerve, which divides 2 centimeters below the ganglion. So all these low vagal lesions are after the superior laryngeal nerve has been given up. The causes of this could be different for right and left, or they could combine both. On the right side, remember that the right vagus nerve is shorter. There could be conditions such as neck trauma, benign and malignant thyroid lesions, iatrogenic injury during thyroid surgery, carcinoma of the cervical part of the esophagus, cervical lymphadenopathy. So in these cases, it could either be direct injury of the nerve or pressure caused on the nerve. Yes. Then conditions such as aneurysm of the subclavian artery, carcinoma of the apex of the right lung, tuberculosis of the cervical pleura, and sometimes even idiopathic. On the left side, same things. The first few will be same. And since the left has a longer pose and reaches the thorax even deeper into the mediastinum than on the right side, you can see that the left is affected in far more conditions such as your bronchogenic cancer, carcinoma of the thoracic esophagus. So we have discussed the cervical esophagus, even the thoracic esophagus disease can cause a left recurrent laryngeal nerve paralysis. aortic aneurysms, mediastinal lymphadenopathies, enlarged left auricle, intrathoracic surgeries, and sometimes idiopathic lesions. So when there is a combined or a both-sided bilateral laryngeal paralysis, this can be commonly seen in conditions of iatrogenic thyroid surgery injuries, carcinoma of the thyroid, carcinoma of cervical esophagus, and bilateral cervical lymphadenopathies. So this can cause a both, that is both the right and left recurrent laryngeal nerve paralysis. There could be some systemic causes which cause some neural abnormalities in the long run, such as your diabetes, syphilis, diphtheria, typhoid, streptococcal infections, viral infections, lead poisoning, etc. Though these specific causes have been mentioned, more than 30% of the causes of laryngeal paralysis are idiopathic. So for no reason, you can see there is laryngeal paralysis which has occurred. But in spite of a particular cause not being found, an entire panel of investigations need to be done to label it as idiopathic. Okay. Starting with the unilateral recurrent laryngeal nerve paralysis. So this unilateral RLN palsy results in ipsilateral paralysis, or the same side paralysis of all the intrinsic muscles of the larynx except your cricothyroid. So cricothyroid is the only muscle supplied by your superior laryngeal nerve amongst all the intrinsic muscles of the larynx. So except this cricothyroid muscle, there is a unilateral paralysis of all the intrinsic muscles of the larynx on that side. Here, the vocal cord assumes a median or a paramedian position and does not move laterally on deep inspiration. So to know this, you need to know what the positions of the vocal cords is. So apart from median and paramedian, so tell me how many positions of vocal cords is described. Yes, there's a median, there's a paramedian. What else? What are the other positions of your vocal cords? Is everybody sleeping? You can even name, give me a number. Cadaveric, very good. That is the third one, median, paramedian, cadaveric, and there's two more. Okay, very good. At least one of you is awake. I'm happy to hear that. Slight abduction, very good. And full abduction, very good. So these are the positions of the vocal cords. There is a median position, nothing but the vocal cord in the midline. So this picture has been given to just show you that they are describing one vocal cord and this is the other one. This is just for descriptive purposes. So both the vocal cords would be in median positions when you're trying to speak or when you're trying to cough. Both the vocal cords have to seal the larynx to create that intrathoracic pressure to cough. So both the vocal cords will come in median position. So what happens is that vocal cords are at different positions at different stages of respiration or different uses of voice. So when you speak or when you're whispering or when you're taking a very deep inhalation or when you're coughing, vocal cords tend to take up specific positions. So vocal cord has this range of motion from median to full abduction. Okay, this entire range of motion should be there for a normal healthy vocal cord. Whereas in the cases of laryngeal paralysis, what happens is that this vocal cord does not move and it gets stuck at a particular position. That is what it means by saying that in a unilateral RLN palsy, the vocal cord is either in a median or a paramedian position. So this is described within particular millimeters from the midline. Yes. So I think in your, I don't know if it's for your seniors, so you have been given multiple choice questions saying when the vocal cords are in intermediate position or in cadaveric position, what is the length of the glottic chink? So glottic chink is the space between your vocal cords. So see that in a median position of vocal cords are in the midline, paramedian 1.5 mm from the midline, from the center of the larynx. Intermediate or the cadaveric position will be 3.5 mm, gentle abduction 7 mm, and full abduction 9.5 mm. So coming back to the question, when we say that, so if I'm saying that in the case of both the vocal cords being in cadaveric position, what is the width or your distance between the two vocal cords of in the glottic chink? When both the vocal cords are in cadaveric position, what is the distance between both the vocal cords? So 7 mm. So that is the correct answer. What this has been given over here is that this is the distance from the midline only. So if you have to measure the distance between both the vocal cords, you have to double this. So that will be the distance between the vocal cords or the width of your glottic chink. So see, in cases of phonation, when you have to create some amount of thoracic pressure or when you want to cough, what happens in a healthy person, the vocal cords are seen in the midline both sides in phonation. Yes, when you phonating, you see them in the midline. The diseased part we will discuss further. When do you see it in a paramedian position? When you are doing a whisper. Whisper is when there is some amount of air leak also. So in that case, you will see both the vocal cords will be in a paramedian position. Cadaveric position is not usually seen in any particular use of the voice. This more often is a passing phase. So while the vocal cord goes from the median to full abduction, it is in a cadaveric position at a particular point, but specific use of cadaveric position for vocal cords is not seen in a healthy person. In quiet respiration, you see that there is a gentle abduction, that is lateral movement. And when you take a deep inspiration, your vocal cord must be able to reach full abduction, that is 9.5 millimeters from the midline on each side. So this is supposed to be in a healthy person. So when you talk about a diseased larynx, when you talk about recurrent laryngeal nerve paralysis, we have discussed that recurrent laryngeal nerve supplies all the muscles except your cricothyroid muscle. So once the cricothyroid muscle is present, it has some amount of, yes, what action? It is an adductor. So it has some amount of adductor action apart from being a tensor. So because of that, instead of being in a cadaveric position, in recurrent laryngeal nerve paralysis, we see that because of the adductor action of the cricothyroid, instead of cadaveric position, the vocal cords are either seen in a paramedian position or in a median position. This cadaveric position is when there is a complete paralysis of both the nerves of the recurrent and the superior laryngeal nerve. There is no effect of any muscle on the vocal cords. You will see that the vocal cords are in the cadaveric position. Yes, and conditions where your adductors are paralyzed. Yes, the adductors are paralyzed. You will see the vocal cords in a gentle abduction. So these are the positions of vocal cords. So here the vocal cord assumes a median or a paramedian position, and you have to stress on this. It does not move laterally on deep inspiration. So the vocal cord is stuck at this position. It cannot abduct further as your posterior cricoarytenoid is supplied by RLN and it has been paralyzed this side. So these are the same causes of the lower vagal lesions or your recurrent laryngeal nerve paralysis. We have discussed this. Here you have to know about these two theories, which also happen to be 2 marks questions. So in easier terms, what the Wegener-Grossman's theory means is that in the cases of a unilateral recurrent laryngeal nerve paralysis, since the cricothyroid muscle, which receives innervation from the superior laryngeal nerve, is intact, this keeps the cord in the paramedian position due to its adductor function. This is in short. This is to easily understand. But what this theory actually states is that in the absence of a cricoarytenoid joint fixation. Fixation means that the joint is not able to freely rotate on top of each other. So cricoarytenoid joint is more like a rotatory joint. So in the absence of this joint fixation, when there is an immobile vocal cord, we have seen this is immobile. It does not move laterally. On deep inspiration, it is stuck at that particular position. So in the absence of this joint fixation, an immobile vocal cord present in a paramedian position means that there is a pure unilateral recurrent laryngeal nerve paralysis. Yes, and an immobile vocal cord in the lateral position, that is cadaveric or beyond, mostly cadaveric. It has a combined paralysis of both the superior and recurrent laryngeal nerves. So in the first case, the adductive action of the cricothyroid muscle is present, whereas when it is more lateral, it is both the nerves because the adductive action of the cricothyroid muscle is lost. So this is the Wigner-Grossman's theory. This is a very common 2 marks question. The second is the Siemens law, also a 2 marks question. So what does this explain? This law explains the median or the paramedian position of the vocal cords. It states that in all progressive lesions of the recurrent laryngeal nerve, the abductor fibers of the nerve, abductors are your posterior cricoarytenoid. So the abductor fibers of the nerve, which are phylogenetically newer, that is the last to be produced during embryogenesis, are more susceptible and thus first to be paralyzed compared to your adductor fibers. So what it states is that the last formed muscle fibers embryologically are your adductor fibers. These are the last to be formed, but these are the first to be injured during paralysis of your recurrent laryngeal nerve. So once the paralysis of the recurrent laryngeal nerve begins, the abductor fibers are first injured, followed by your adductor fibers. So Siemens law states that because the adductor fibers are destroyed later, in a later stage, and there is loss of abduction, the cord tends to assume a median or a paramedian position. Okay, to come into a median paramedian position, there needs to be adduction, a double D, adduction. So when the abduction is lost, automatically this adduction muscles compensate initially and get the muscle into the median or the paramedian position. So this is the Siemens law. The clinical features we see in a unilateral recurrent laryngeal nerve paralysis is mostly asymptomatic. Why? Because the healthy vocal cord tends to compensate, that it crosses over the midline, that is goes over the median position and goes over to the opposite side to meet the paralyzed cord. This compensation usually happens between 6 to 8 months sometimes, or weeks also. So in most people who are not professional users of the vocal cords, or people who don't modulate voice as much from day to day, you will see that the patient does not have much of symptoms. Some people may complain of change of voice and some amount of cough maybe, and there is tiredness of voice because the other cord has to eventually always compensate this paralyzed cord. We have discussed this. The voice in the unilateral paralysis gradually improves due to compensation by the healthy cord, which crosses the midline to meet the paralyzed cord. This set of investigations is common for all types of laryngeal nerve paralysis. Yes, so you take a CT MRI imaging from skull base to superior mediastinum. Here in a recurrent laryngeal nerve, imaging from skull base is not very necessary because we're talking about recurrent laryngeal nerve paralysis. This branch is given off at a lower level. But then, just to be doubly sure, we take a CT MRI from the skull base to the superior mediastinum. Then you take a chest X-ray to rule out any mediastinal lesions. We have talked about this. They could be bronchogenic carcinoma, they could be TB of the cervical pleura. So these kind of lesions, to know this, you take a chest X-ray. It can also be seen in a CT and MRI. And to rule out any presence of aspiration pneumonias. Since one cord is in a median paramedian position, when it is in a paramedian position, it is unable to completely adduct also. So it can lead to some amount of aspirations. Aspiration happens when both the cords are not able to completely meet in the midline. So in a unilateral recurrent laryngeal nerve paralysis, initially before the compensation occurs, there is some space in the glottic chink which is not closed. So this can lead to some amount of aspirations. So we have to rule out aspiration pneumonia. You do a spiral CT of the lung. Okay, it also helps in diagnosing mediastinal conditions causing paralysis. Then we do a direct laryngoscopy, a pan endoscopy, and speech analysis. So what is a pan endoscopy? Pan endoscopy is nothing but your endoscopy done from the nose to the bronchus and also the esophagus. So how is that? It has multiple components. It usually comprises of your nasopharyngoscopy, that is something to do with the examination of the nose and the nasopharynx, one. Then it is the examination of the oral cavity and oropharynx, two. Next will be your hypopharyngoscopy, the third part of your pharynx. Next will be your direct laryngoscopy, and the other two will be your bronchoscopy and esophagoscopy. So pan endoscopy from the nose to the bronchus and also the esophagus, every part should be examined. This is called as pan endoscopy. So instead of doing a separate nasopharyngoscopy, hypopharyngoscopy, laryngoscopy and bronchoscopy separately, we have new devices such as your nasophryngobronchoscopes. This is nothing but in a short name called as a flexible bronchoscopy. In the flexible bronchoscopy, you pass the bronchoscope through the nose. So it passes through the nose, nasopharynx, oropharynx, hypopharynx. You can visualize the larynx and go inside the larynx up to the level of the bronchi. In this, additionally, you will have to just examine the oral cavity. Yes, so a pan endoscopy is done to locate any lesions, and a speech analysis should be done when the patient is complaining of change of voice. The treatment of a unilateral recurrent laryngeal nerve paralysis is mainly wait and watch in most of the cases, as cord compensation occurs between 6 to 18 months in most cases. Whereas in patients who are complaining of certain amount of voice change and discomfort or some amount of aspirations, you need to go into surgical measures. So a range of surgical measures are available, the aim of which is to allow the paralyzed vocal cord to contact the normal vocal cord during phonation. Okay, not only during phonation, during swallowing, and also to improve patient's ability to cough. So for all these three functions, phonation, swallowing, and coughing, both the vocal cords need to meet in the midline. For this to happen, you need this paralyzed cord, which is in a paramedian position, to come and meet the normal cord in the midline. So what do? We do static measures or dynamic measures. Static measures meaning that they do reposition the vocal cord towards the midline, but it does not give any active motion to the paralyzed cord. Dynamic procedures, not only do they reposition the cord, but this paralyzed vocal cord tends to develop some amount of range of motion. So static measures which we use are laryngeal framework surgeries or injection laryngoplasties, and dynamic procedures will be your nerve to nerve anastomosis or your nerve to muscle pedicle transfers, which we will discuss going further. So static measures, firstly, your injection laryngoplasty is nothing but your injection of a material laterally into the vocal cord to displace it medially. Very simple. So what do? You can do it both ways, but here in the cases of a unilateral recurrent laryngeal paralysis, what we do, we inject. This is the thyroid cartilage. Okay, this is a cut section, mostly your axial section. This is your false vocal cord. This is your true vocal cord. So in this, we are injecting a material laterally into the vocal fold to displace this cord medially. So once you fill up this space, this automatically pushes the vocal cord medially. An ideal injectable material would lack any antigenic response. That is, it does not cause any rejection or anaphylaxis. So it should have similar viscoelastic properties to that of the vocal cord. It has to be resistant to resorption and migration. So it should not be absorbed completely. Otherwise, its effect is lost. And it should be easy to prepare and inject with precise control. So examples of such substances are Teflon, collagen, wax, calcium hydroxyapatite, polyacrylamide, gel, and fat. So of these, in recent times, Teflon is being slowly reduced as this is causing some amount of reactions or granuloma formations. Fat could be resorbable, so not very much preferred. The other kind of substance which we use is the gel foam. Gel foam we use it mostly in microotological surgeries. This gel foam can also be used when you want a temporary medialization of the cord when you are expecting a full recovery in the coming months. The next is your laryngeal framework surgery. So your laryngeal framework surgery is nothing but your thyroplasties. So types of thyroplasties is also probably a 2 marks question and also a 4 marks question sometimes. Thyroplasty types we will discuss towards the end of the class. There are, so here in the unilateral recurrent laryngeal nerve paralysis, we need a medialization of the cord. So we use a type 1 thyroplasty, which is called as a medialization thyroplasty. What happens is you give an incision on the thyroid cartilage, create an incision on its perichondrium, elevate the perichondrium, create a window in the ala of the thyroid cartilage, and you push in a silastic or a vortex implant. This implant also acts to push this paralyzed vocal cord medially. So it involves the placement of a silastic implant or vortex implant related to the vocal fold via a window cut in the thyroid cartilage. The silastic displaces the vocal fold medially and it ensures adequate glottic closure. So whatever we do here, both in the injection laryngoplasty and in your laryngeal framework surgery, it is to medially push the vocal cord towards the unparalyzed cord. We will discuss about these dynamic procedures towards the end. So nerve pedicle transfers are nothing but a part of a nerve from another location along with its nerve supply. Something like your omohyoid or your sternohyoid muscle along with its nerve supply is brought and sutured in this region so that the vocal cord tends to get back its supply. Okay, so you use this muscle as a pedicle transfer, or you can even anastomose the paralyzed recurrent laryngeal nerve to the ansa of that size of the same side so that there is a nerve to nerve anastomosis. Okay, so this can also produce some amount of motion in the paralyzed vocal cord. We will discuss this further. The next will be your bilateral recurrent laryngeal nerve paralysis. This other name is your bilateral abductor paralysis. So a unilateral RLN palsy is called a unilateral abductor paralysis, whereas your bilateral RLN palsy is also called a bilateral abductor paralysis. So in this, you see that all the intrinsic muscles of the larynx are paralyzed. The vocal cords on both the sides lie in the median or a paramedian position. Yes, as there is an unopposed action of lipothyroid muscles on both the sides, this will dangerously narrow the distance between the vocal cords and reduce the glottic chink. That is, even during a deep inspiration, the vocal cords are not going into full abduction. So there is a very narrow glottic chink. This will automatically lead to dyspnea and stridor, which is a very grave complication. Voice will be more or less normal because cords if in median position, phonation will be normal. We have discussed that for voice, cough, for phonation, cough, we need phonation, cough, and swallowing, we need the vocal cords to be in a median position. Since that is already achieved, the voice may be normal in these patients. But in patients when they are in a paramedian positions, sometimes they might complain of very slight voice changes. The causes for a bilateral recurrent laryngeal nerve paralysis are most commonly after iatrogenic thyroid surgeries. Yes, the investigation panel is the same again. CT, MRI, chest X-ray, spiral CT, direct laryngoscopy, pan endoscopy, and speech analysis. So what do you see here? During expiration, we expect the vocal cords to, this is the anterior commissure. So during expiration, you want them to be in a full abduction. But in the cases of bilateral abductor paralysis, this abduction does not happen. So there is not really much gap between the vocal cords even during expiration. So this leads to a lot of distressing stridor. So the treatment mainly here, in acute cases of stridor, tracheostomy may be required. But in patients who are comfortable, who have vocal cords in paramedian position, you can give them 6 months and wait for a spontaneous recovery, which is very rare in these conditions. So if the patient does not want a tracheostomy, tracheostomy gives more or less an unsightly appearance. So in younger age groups or in patients who do not wish to have this kind of a tracheostomy tube popping out through the neck, there are procedures which can be done to lateralize the cords. So in the cases of a unilateral recurrent laryngeal nerve paralysis, the other cord is able to fully abduct. This paralyzed cord is stuck. So we want to bring the paralyzed cord medially so that it can meet the moving normal cord when it's in the median position to improve the voice. Here there is no compromising of the glottic chink as the other cord is able to completely abduct. Whereas in a bilateral recurrent laryngeal nerve paralysis, what happens is both the cords are stuck in a median position. There is already no space. So what do you want? You want to lateralize the cords, at least one cord. So what do? We opt for vocal cord lateralization through endoscope. That is, we fix the vocal cord by using a suture either through the thyroid cartilage, the subcutaneous tissue over that. This is on the thyroid cartilage, and sometimes this is the skin. So this is again your cut section, axial section we're seeing from top. So this will be a vocal cord, thyroid cartilage, perichondrium muscles attached to it this way, and this is your skin. So we can fix this vocal cord or move it laterally by tying the suture to the vocal cord and tying that suture on thyroid cartilage or outside on the skin. We can do a posterior cord dotomy. Dotomy is this. So the posterior part, we are seeing that these vocal cords are unable to abduct. When they abduct, they are supposed to come to these positions. So if they are unable to abduct during expiration, so what we do to create some amount of space for air, we do a posterior cordotomy. The posterior part of one of the vocal cords is cut off using laser or microsurgical instruments. Then we can do a partial arytenoidectomy. The medial part of arytenoid, sometimes only vocal process of the arytenoid is removed. So this is the arytenoid. This is the vocal process. This part can be removed. This will also widen the glottic chink. We can do a type 2 thyroplasty. It's again a lateralization thyroplasty. And we can also opt for nerve muscle implant. We have discussed this, a sternohyoid or an omohyoid with its nerve supply from your ansa hypoglossite. So this can be used as a nerve muscle pedicle transfer. So this is endoscopic suture lateralization, laser posterior cordotomy. Coming to your superior laryngeal nerve paralysis, it could be again unilateral or bilateral. When it is unilateral, there is paralysis of the cricothyroid muscle of that side only and ipsilateral anesthesia of larynx above the vocal cord. Same-sided anesthesia of the larynx above the vocal cord. Cricothyroid muscle is supplied by your external branch and your sensory supply is by your internal branch. So both of this on one side are lost. What are the causes? More commonly seen in thyroid surgeries, in thyroid tumors of one side or one lobe of the thyroid, and cases of diphtheria. So this cricothyroid muscle is the major tensor of the vocal cord. So since this tensor is paralyzed, the voice becomes weak. The patient is unable to raise pitch due to the loss of tension. So this is seen as a problem mostly in professional voice users such as musicians. The voice becomes monotonic. Anesthesia of the larynx on one side, though the one side is paralyzed, the anesthesia of the upper part of the larynx on one side is seen. The other side tends to compensate more or less. And because there is this anesthesia, sometimes there can be aspiration, and this condition may be overlooked as compensation occurs early unless the patient is a professional singer because he is not able to raise his pitch. So what signs do you see? Since the tensor of this side is lost, the tensor of the opposite vocal cord tends to take over. This gives a change in the direction of the anterior commissure. So what is the anterior commissure? This is the anterior commissure. So let's say that this cord has a unilateral superior laryngeal nerve paralysis. So tension is lost. This is very tense. So what does it tend to do? It tends to turn the anterior commissure towards itself. So the inlet of the larynx, instead of being straight, it becomes oblique. So anterior commissure is rotated to the healthy side. The vocal cord appears shortened because there is a loss of tension, and it appears wavy because of the same reason. Cord could be seen as bowing during phonation, and this cord also flaps or sags down during inspiration and bulges up during expiration. All these are because there is a loss of tension or stiffness in the vocal cord. Investigations. Here, apart from the entire panel we have discussed, we tend to do a video stroboscopy because only then you can appreciate the flapping of vocal cords or your bowing. But then oblique laryngeal inlet and shortening of vocal cords can also be noticed with your direct laryngoscopy. These have to be seen with the video stroboscopy. So what is a stroboscope? Stroboscope is nothing but a device to analyze the movement of the vocal cords in slow motion. What the stroboscope does, it records the movements of the vocal cords during phonation up to a particular interval, and when you play it, it plays it in slow motion. So because of that slow motion, you can particularly see the movements of the vocal cords. Even the waveform of the vocal cord can be seen with stroboscopy. So the treatment here for a unilateral SLN palsy is that to wait and watch in most cases as spontaneous improvement occurs. When that is not there, then we use an injection laryngoplasty. Yes, we do a Teflon or collagen injection into vocal cords under operating microscope so as to increase this lost tension. And an arytenoid adduction procedure may be helpful in lengthening the vocal cord on the affected side. So arytenoid, as you know, is not just a particular part, it is a rotatory joint. So if you adduct it, then automatically the tension in the vocal cord increases. When there is a bilateral superior laryngeal nerve paralysis, which is not very common, both the cricothyroid muscles of both the vocal cords are paralyzed along with complete anesthesia of upper larynx. So more than anything, because of this anesthesia of upper larynx, the patient tends to have severe aspiration. So this can be seen rarely, but in conditions of surgical or accidental traumas, diphtheria, bilateral cervical lymphadenopathies, and a progressed neoplastic disease. Here, the main problem is aspiration, as the entire both sides of your upper part of the larynx above the level of the glottis is paralyzed. So the patient complains of majorly coughing and choking spells. Breathy voice with inability to raise pitch as usual because the cricothyroid muscle on both the sides are paralyzed. The patient is unable to raise pitch. And as signs, same in the cases of unilateral superior laryngeal nerve paralysis, but you see that the changes are bilateral. Okay. Don't think there are pictures anywhere. Okay. So this is the panel of investigation, same again. And here in treatment, to prevent this severe aspiration, firstly we can do a tracheostomy so that you cut off that area of the vocal cord palsy from which the aspiration can happen. So when you do a tracheostomy, you're bypassing the larynx for breathing. Okay, so it will cut off that aspiration to that part. And for feeding, you have to put in a rice tube, given esophageal feeding tube. When the aspiration is very severe, what you do is you close the inlet of the larynx by completely suturing both the vocal cords and aryepiglottic folds and false cords to each other. So 3 layers, aryepiglottic fold inside most will be your vocal cords, above will be your false cords, above will be your aryepiglottic folds. So 3 levels, both sides, we suture it along the anteroposterior line of the larynx. So you can do a epiglottopexy. Epiglottopexy is where the epiglottis is sutured back onto the inlet of the larynx to cover it. In other ways, you can also suture true false cords and aryepiglottic folds to each other in a vertical anteroposterior line to close the inlet of the larynx in cases of severe aspiration. So coming to your combined vocal cord paralysis, where both your recurrent and superior laryngeal nerves are paralyzed. This could be just on one side. Paralysis of all the muscles of the larynx on one side except your interarytenoid. Interarytenoid is a combination of your transverse arytenoid and your oblique arytenoid muscles. Oblique arytenoid is responsible for closing the inlet. Your transverse arytenoid is responsible for adduction of the cords. So these theoretically receive innervation from both the sides of vagus. So when this is a unilateral vagus, complete vagal paralysis, this nerve sometimes tends to be spared. So this can be seen in conditions of thyroid surgeries. It is not very common in thyroid surgeries actually, but it is more common in your nuclear lesions. So we have discussed nuclear lesions, conditions such as your multiple sclerosis, Guillain-Barré syndrome, syringomyelitis, Wallenberg syndrome, all these cases, fractures of skull base or osteomyelitis of skull base, all these conditions can cause a unilateral combined vagal paralysis. So in a combined vagal paralysis to occur, the injury or the lesion needs to be above the level of the branching of superior laryngeal nerve. So it has to be inside the cranium or just at the level of the nodose ganglion or above. Below that, the branches are given, so it cannot cause a combined paralysis. Clinical features, all the muscles of the larynx on one side are paralyzed. Because of this, you see that the vocal cords are in a cadaveric position. There is no abduction, there is no adduction, so vocal cord lie in a cadaveric position. There is glottic incompetence as the healthy cord is unable to approximate to the paralyzed cord. So in cases of a unilateral recurrent laryngeal nerve paralysis, we have seen that the cord is in a median or a paramedian position. Even though it is in a paramedian position, the healthy cord can compensate because paramedian from the midline has only a few distance. But in cases of a complete vagus nerve paralysis, this compensation cannot occur because this paralyzed cord is more away from the midline than the paramedian position. So some amount of glottic incompetence is always there. Okay. Cough will be ineffective due to air waste. Obviously, again, the cords are not able to meet each other. The treatment mainly will be speech therapy. In speech therapy, what they do, they hasten the process of compensation by certain maneuvers, certain ways of positioning of your head, neck, or your use of voice. They tend to hasten the process of compensation. If not completely, to an extent, it may improve the voice. Here also we use procedures to medialize the cord. That will be your type 1 thyroplasties or your injection laryngoplasties. Here the aim is to bring the paralyzed vocal cords to the midline so that the healthy cord can meet it. You can do an injection laryngoplasty, inject it to the lateral aspect of the vocal cord to push it medially. Or we can do a type 1 thyroplasty by using a stylistic implant from the thyroid ala side so that the vocal cord is pushed medially. Then there is a bilateral vagus or a bilateral complete laryngeal paralysis. That means both the superior and recurrent laryngeal nerves on both the sides are paralyzed. This is very, very rare. Okay, it does not happen very usually. It is a very rare condition. We see that both the cords are in cadaveric position, very away from each other, huge glottic chink, and there is total anesthesia of the larynx. So this is a perfect combination for a very bad case of aspiration, leading to aspiration pneumonias. So clinical features here, there is aphonia. Patient is unable to speak as the vocal cords do not meet at all, as the glottic chink is too wide to cause any sound. There is extreme aspiration and due to a completely open glottis and a complete laryngeal anesthesia, because both all the nerves are lost, so there is no sensation at all. There's inability to cough. Even though there is some amount of aspiration, the patient cannot cough because the cords do not meet again. This might ultimately lead to repeated aspirations, retention of secretions, and bronchopneumonia. Investigations, I have skipped it somehow by mistake. Same panel again, like the previous cases of paralysis. The treatment here is mainly to prevent this aspiration or further control it. So you can do a tracheostomy, cut off the larynx from the pathway of breathing. This can also help in removing the already present pulmonary secretions. For feeding, you give a Ryle's tube or you can give a gastrostomy. Up to you. Then here we need to again do a vocal cord plication. So epiglottopexy is where you suture the epiglottis over the top of the inlet of the larynx. Vocal cord plication, like we have discussed, is you are suturing the true cords, false cords, true cords lower below, false cords above that, and areglottic epiglottic folds above that in 3 layers to completely close the inlet of the larynx. This is called as vocal cord plication. This is done in a technique called laryngofissure. Laryngofissure is nothing but splitting the thyroid cartilage from superior to inferior in the midline, separating it at the anterior commissure level. This is a laryngofissure. Okay. Then you can do a total laryngectomy when the cause is progressive. That is, no matter the surgery, if you think that beyond that the pathology is going to progress, we do a total laryngectomy. And when the speech is also unserviceable because you cannot preserve it, you cannot salvage it, what we do to prevent repeated aspirations and lung infections, we remove the entire larynx. And the other option is a diversion procedure. Diversion procedure is where a trachea is divided at the 3rd to 4th tracheal ring. The upper part of the trachea is anastomosed to the esophagus. Okay, this function of closing of inlet of larynx during deglutition is lost. So what happens? You divert the upper part of your trachea to the esophagus, and so whatever is aspirated into the larynx in that person goes directly into the esophagus, whereas the lower part of the trachea is brought out as a tracheostome from the neck. Okay, so this is a diversion procedure. So we have discussed multiple procedures here. In short, phonosurgery can also be a question for you. So phonosurgeries are the surgical procedures that maintain, restore, and enhance human voice. These are your microlaryngeal surgeries. Microlaryngeal surgeries are microscopic larynx surgeries using, as the name suggests, a microscope or an endoscope with microsurgical instruments. The next is your injection laryngoplasty. We have discussed this. Injection of certain substances medially or laterally to the vocal cord so as to push it in the opposite direction. The next is your thyroplasty. So thyroplasty has been divided into 4 types by Ishiki. So these are called Ishiki's grades of thyroplasty. These are 1, 2, 3, and 4. The type 1 we use in a unilateral recurrent laryngeal nerve paralysis we have seen, and also in a unilateral SLN palsy, which is, it is the medial displacement of the vocal cord. It is the most common surgery of unilateral vocal cord paralysis for whichever reason. Type 2 is a lateral displacement of vocal cord. It is used in cases of airway insufficiency to improve the airway. Type 2 we have seen in cases of bilateral abductor paralysis. Yes. Type 3 is to shorten the vocal cord, is to relax it and to shorten it. What happens when it is tense? It has a high pitch. Females have a high pitch voice, whereas men tend to have a lower pitch baritone. So type 3 or type 3 thyroplasty, it is used to shorten or relax the vocal cord. This lowers the pitch, and this procedure is done in those who have undergone gender transformation from female to male, and also in falsetto voices. Type 4 is the opposite of type 3. It is the procedure used to lengthen or tighten, increase the tension in the vocal cord and to elevate pitch. So what happens? It converts the male low pitch character of voice to a female high pitched character of voice, which is also used in gender transformation from male to female. This lengthening or tightening of the vocal cord can also be used in old age, where the vocal cord becomes laxed or becomes unable to function to its complete capacity because of bowing. Its inability to function causes some amounts of voice abnormalities. So in those cases also we can lengthen or tighten the vocal cord in cases of also trauma. So this is your phonosurgeries. Thank you. Of these questions, any part of your laryngeal paralysis? Most commonly, I have noticed that your bilateral abductor paralysis tends to be a 4 marks question. But apart from that, unilateral or bilateral, recurrent laryngeal nerve, superior laryngeal nerve, or combined paralysis, either of those have been given as 4 marks questions. And 2 marks questions from here will be your Siemens law and Grossman's, Wegener-Grossman's theory, these two. Phonosurgery has been a 2 marks question as well as a 4 marks question, especially thyroplasties. That's about it, I believe. We have already discussed congenital laryngeal paralysis and congenital lesions of the larynx. So I think we'll stop here. Any doubts, you can ask me. If you'd like to ask me in the next class also, we'll be available. Yes. Okay, thank you.